the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in treatment of chronic pain. This series is one of many resources made available by the Prescriber Support System, Opioid Therapies, a program that is funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations: the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. Before we start the presentation, I just want to go over a few quick housekeeping notes. In the upper right side of your computer screen, you'll see a control panel. In the lower portion of that panel, you can type in a question or comment and submit it to the webinar organizers. You can do this at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. And if we're unable to get to all those questions in the allotted time, our presenter has agreed to respond to them in writing. The webinar, presentation slides, and questions and answers will be posted on the PCSSO website in the near future. Those materials will also be posted at the INSA website at www.intnsa.org. So without further ado, let me turn to our presenter for today. Today, Mr. Matt Tierney will address integrating opiate agonist treatment in primary care and mental health settings, a clinical model. In this presentation, he will detail structural and procedural elements that help to promote the integration of opiate replacement therapy in primary care and mental health settings, describe the barriers to integration of opiate replacement care with primary care and mental health, and describe existing and potential contributions of nursing roles at all levels, LVN, LPN, RN, and advanced practice, in promoting the integration of opiate replacement care with primary care and mental health treatment. Matt Tierney is a nurse practitioner who holds a Master of Science degree in nursing from the UCSF. He directs 2 opiate replacement treatment programs that are part of San Francisco General Hospital's Department of Psychiatry in the Division of Substance Abuse and Addiction Medicine. He is the former director of San Francisco General Hospital's Addiction Medicine Consultation and Treatment Service. Matt is a clinical faculty at the UCSF School of Nursing and is a member of the Motivational Interviewing Network of Trainers, also known as MINT. He's also a member of the American Psychiatric Nursing Association, or APNA, the Association for Medical Education and Research in Substance Use, or MRSA, and the International Nurses Society on Addictions, INSA. Matt also has a consulting practice that focuses on addiction treatment needs, education and training, and motivational interviewing, and topics related to co-occurring disorders. With this, I'd like to turn it over and give a warm welcome to Mr. Tierney to begin today's presentation.
Well, thanks so much, Deb. It's great to be invited to be part of this terrific PCSS series. And also a shout out to everybody at the INSA office, including Monica Evans-Lohm, who's helped so much in organizing today's presentation. I really appreciate it. So the clinical model I'm going to describe today is about our office-based buprenorphine induction clinic, or as we call it, OBIC, O-B-I-C. And it's a program of the San Francisco Department of Public Health's Behavioral Health Division, which is called Community Behavioral Health Services, or CBHS. And it's staffed by contract by University of California, San Francisco. CBHS is the division of the Department of Public Health here in San Francisco that contains all substance abuse and mental health services for the city and county of San Francisco. I want to mention, for those of you who are attending the webinar today, you may have heard me give a very similar presentation a year ago at a NASADAD webinar, or if you were at the California Society of Addiction Medicine's conference in November of this year, I gave a similar presentation on our clinic as well. I think the key difference with today's presentation is, especially towards the end, I focus a lot on nursing contributions to opiate agonist treatment in our clinical setting. I do want to disclose that I am a member of a speakers panel for the Contemporary Forums seminars at this annual psychiatric nursing conferences. And Deb has already mentioned the objectives today, so I'm not going to spend any additional time on those, but they're printed here on the slides for you. So I think it's good to start with a little bit of background. And we know that historically, people with opioid use disorders or opioid dependence have needed more treatment options than historically have been available, and that the Drug Addiction Treatment Act of 2000 expanded opioid replacement treatment options. And we also know that many, though not all, providers in primary care and in mental health clinics often feel unprepared to provide buprenorphine treatment or addiction treatment in general. So in this fragile treatment context, we have the 2010 Affordable Care Act, which really prompts the integration of addiction care and primary care integration of addiction care and primary care, or addiction care and mental health care. So what is OBIC and how did it get started? Or more to the point, why do we need OBIC, an office-based buprenorphine induction clinic? Well, by history in 2003, just prior to the FDA approval of buprenorphine for opiate replacement therapy or opiate agonist treatment, the San Francisco Department of Public Health provided one of the early 8-hour trainings in opiate addiction in order for physicians to obtain a DEA waiver to prescribe buprenorphine. And at that 2003 training, more than 200 Department of Public Health physicians attended. And in the training, a very clear protocol for buprenorphine induction was presented. And the attending physicians there said, well, have you ever been to my public health clinic? There's no way I'm ever going to be able to initiate buprenorphine treatment according to what was just presented. We don't have the time or the space or the support staff at our clinic to do the dosing and monitoring for patients and provide the frequent follow-up appointments until they're stable on the medication. And in addition, the physicians were really afraid of having to manage any possibility of precipitated opiate withdrawal. So while they thought it would be a good idea to have some of their patients on buprenorphine who needed it, they felt there was no way they could perform the inductions in their clinical settings. And so our founders here at the SFDPH, Drs. David Hirsch and Alice Gleghorn, said, well, gee, what if it was done for you? And really that was the birth of OBIC. It started in 2003 then as a research pilot that ran for 2 years, and then in 2005 became a city-funded program. So really from its very inception, the focus was on integration and integrating opiate replacement and opiate agonist treatment in primary care or in mental health settings. So the motto of community behavioral health services is that any door is the right door to treatment. And there are many doors or routes to integrated care with the involvement of OBIC. One of them is community-based primary care here at the top of the diagram, and mental health providers in the Department of Public Health who have DEA waivers to prescribe buprenorphine can refer patients directly to OBIC for treatment induction, and once the patients are stable, they're referred right back to the mental health or the primary care providers. Another door involves needy patients who are identified in other treatment settings. These can include the San Francisco Homeless Outreach Team or needle exchange sites. You know, we have a lot of needle exchange sites in San Francisco. And at those sites, counselors and public health workers and outreach workers refer patients to OBIC for treatment. And if those patients already have DEA waived doctors who provide their care, we refer them to their existing care once induction and stabilization occur. But another door also includes patients who are in other care, sometimes specialty care. These can include methadone clinics or pain clinics or the emergency department or even jail. We've just started a big linkage with the San Francisco County jails. So patients can be referred to OBIC for treatment, and once they're transferred, once they're stable, we transfer them to existing providers. But I've got a question mark down here at the very bottom of this slide. What about those patients who aren't connected with any health care? Well, for many of our patients, our site is the very first treatment site they ever encounter in San Francisco, or it's the first time they've been back in any healthcare treatment in a long time. And patients can self-refer to us and receive comprehensive assessments. Those patients who are unconnected receive comprehensive assessments by our medical and nursing staff. And that includes comprehensive mental health, comprehensive health histories and physical exams to assess what their more comprehensive needs are in addition to buprenorphine. Once patients are on a stable dose of buprenorphine, we link them with ongoing care that's integrated with the primary care they need or the mental health care they need, hopefully in the neighborhoods where they live or hang out in order to be convenient. I want to describe some of our referring sources to OBIC. These are rank ordered here on the right side. So primary care, up until last fall, when I last looked at these numbers, primary care accounts for 34% of the referrals that come to us. So the primary care clinicians are very interested in referring clients and receiving them back. The second largest group is methadone clinics. 20% of our patients are referred from methadone. And to me, this makes a lot of sense. Patients may have received everything they need to from methadone clinics, and that relatively, to me, a higher level of care and more intensive treatment, and are maybe ready to step down to the less treatment-intensive world of buprenorphine and office-based treatment. Patient self-referrals also account for nearly 20%. It's 19% of our referrals. And patients can just walk into the building. And we often get that. Patients say, hey, a buddy of mine was treated with you guys, and I thought I'd come in and see if I was eligible for treatment as well. Our treatment access program, which is a single entry point to all mental health and behavioral health care. It's a drop-in center on the first floor of our building. That accounts for 14% of referrals. Project Homeless Connect, which is a big every other month forum here in San Francisco, accounts for 7% of referrals. And then the smallest number of referrals come from the community mental health centers. We get about 6% of referrals from there. So OBIC has a standard treatment protocol process for induction and stabilization that I would describe this way. First, we get the referral from any door as I prescribed. Then we meet the referred patient for what we call our orientation appointment. And at that appointment, inclusion and exclusion criteria for buprenorphine are referred. We want to make sure this is the right level of care for patients. We confirm a diagnosis of opiate dependence and sort of point patients to the right level of care. Hopefully it is buprenorphine. If it's not, we can certainly refer patients to methadone or residential treatment or detoxification treatment, whatever seems appropriate. And we often use the American Academy of Community Psychiatry's LOCUS tool, if you're familiar with that, LOCUS, the level of care utilization system. I find it to be very, very helpful. At the orientation appointment, a non-judgmental approach begins. And to me, this is a crucial element of what we do because it really helps with patient comfort and trust. And the technical aspects of the orientation appointment include the review and signing of patient-informed consent. And finally, we review rules and expectations. So eventually, the community provider can refer to the fact that a patient has been oriented to our system-wide informed consent and rules and expectations for take-home dosing, toxicology testing, behavioral guidelines, etc. After the orientation, we schedule the induction. And at the induction, we perform a comprehensive history and physical for medical, psychiatric, and individual needs assessments. And referrals are made based on those assessed needs. And of course, patient needs are more fully evaluated over the course of the coming weeks. And finally, after stabilization, there is the referral to a community provider for integrated care. Patients typically, on average, spend 10 weeks with us. We have them dose with us daily at the pharmacy downstairs. They dose daily for the first week, typically, and then less frequently as they gain stability. And some more on what stabilization means in the coming slides. I've already mentioned that OBIC provides other important services within those basic treatment steps. So we certainly provide medication induction and stabilization as just described. We also provide client-centered counseling and education. And these are very individualized. Really at the core of our counseling is motivational interviewing and harm reduction education. Ongoing services, which I will detail a little further, include restabilization for patients who are failing treatment in the community settings. Counseling can happen on an ongoing basis for clients as needed. And we can also do PRN assessments and toxicology testing while patients are with us, and also once they've moved to their community providers, we're happy to provide additional assessments and toxicology testing on an as-needed basis. OBIC is also a place for provider education, consultation, and support. And to me, this is an extremely important function. So many of our nurses, physicians, pharmacists, social workers do not get the addiction education they feel they need. And we try and provide as much of that as we can. We really have an open door policy with our colleagues. And colleagues of every stripe and certification really come and spend some time with us, shadow us, spend some time in our office, spend time talking with the patients, and I think that's a crucial function that we perform. We also assist providers by providing phone and in-person education and consultation services. Very quickly, I want to present some raw data gathered from patient charts and clinic forms. These raw data on the right for how old our patients are from the time we first opened until last fall. The vast majority of our patients are in their mid-20s to mid-40s to about 50 years old. Very smaller percentages of older adults and late adolescents. I would really love to build those populations up because we certainly know they exist, and I wonder if buprenorphine could be more helpful to those specific populations. And then the gender statistics on the left are just from the year 2012. The overwhelming majority of our patients are male. Again, a little more raw data gathered from patient charts and clinic forms. From inception until last fall, the total number of inductions we performed was 869, and I've listed the average inductions and the average number of monthly clinical encounters. We're a morning-only clinic, so these numbers are just for a 3.5 or 4 hour clinical day, as you'll see, with a very small clinical staff. In the afternoon, we do lots of consultations and assessments. And we also run a different program in the afternoon where the state of California allows us to do all the methadone intake forms for the community methadone clinics and then refer patients for methadone the next morning wherever there's an opening. So we do that in the afternoon. 43% of our patients have transferred to community settings in our history. And their average buprenorphine dose with us is close to 15 milligrams. You might say, well, what's happened to the remaining 57% of the patients you've induced? We've actually just begun analyzing that data. We have a CHR approval to research treatment retention and duration with us. What we do know is some are transferred to other levels of care. That it turns out when we induce them on buprenorphine, it's not the right level of care. They're not responding really well. So we certainly refer patients to methadone from buprenorphine. About 4% of our patients opt to taper off of buprenorphine while they're with us. And a little less than 3% of our patients moved away from San Francisco during their OBIC treatment. And because this is a Department of Public Health funded program, it makes them ineligible for us to continue prescribing buprenorphine for them. And a very, very small percentage, less than 3% actually, are incarcerated, hospitalized, or intolerant of buprenorphine or deceased during their induction and stabilization period. So our staff, who does all of this? Well, right now we have one full-time administrative assistant and a full-time state-certified substance abuse counselor. We have almost 2 nurse practitioners, a full-time and a .9. And we've just had some increased funding to hire another half-time nurse practitioner. And then a half-time DEA-waived physician. Over the years, it's worth mentioning, I've really always seen this as a nurse-run clinic. And when we first opened, the city and county determined our staffing, we had 3 full-time state-certified counselors. But given our patient volume and given the intensity of the medical assessment piece and psychiatric assessment piece, I really felt that psychiatric nurse practitioners would be the best group to cover the most bases in terms of services provided. So the psychiatric NPs can certainly provide counseling, therapy and support, education, motivational interviewing, but additionally they can do the medical histories, the physical exams, the assessment of the response to buprenorphine, check toxicology tests, and really do a higher level, in my mind, of interface with other medical providers in the community, kind of sometimes using the medical language that's necessary. So over time, we've really turned from very much a counselor-run clinic to a nursing-run clinic. And by the way, we really value our counselors very much. We couldn't do what we do without our state-certified counselor. She is a wealth of information and just does an amazing job making therapeutic alliances with our clients. Before detailing our specific functions, which really is the heart of today's talk, the functions that assist in integration, I want to show you our location. This is our building here. The building itself actually and the services within really assist with integrated care and referrals to other behavioral health services in San Francisco. This is the CBHS building in San Francisco, south of Market neighborhood, and OBIC Clinic is on the 2nd floor. The 1st floor houses other behavioral health services, including the Behavioral Health Access Center, and I'll detail what that is in a moment. I've already mentioned TAP, but I'll give some more details, and our licensed CBHS pharmacy, which provides all the buprenorphine for patients who are seen at OBIC. So now I want to discuss our specific functions that I feel assist with integration and what I feel is the value each of those functions bring. So first, as I've described, we provide direct patient care by buprenorphine induction and stabilization. And along with that, we provide patient-centered counseling and education. And the value of these to me is that by the time of transfer to community-based care, buprenorphine is already familiar both to patients and to providers. And I find that in general, community providers are more receptive to integrating care for those patients who are already stable. I often use the old model of the insulin clinics. Remember the nursing-run insulin clinics? And maybe some systems still have them. When diabetic patients needed insulin care, they were referred to the nursing-run insulin clinics. They were stabilized on their doses of insulin and then referred to their primary care providers for ongoing treatment. I really see OBIC in very much this regard when it comes to the medication piece. And remember that the genesis of OBIC was that community providers felt that the induction and stabilization processes would be too burdensome to their busy public health clinics. So really OBIC just takes that off their hands. Another important function is that OBIC clinicians perform comprehensive health and mental health assessments and referrals, as I mentioned. And the value here is to connect unconnected patients with needed primary care or mental health care, always remembering in our system that any door is the right door to treatment. For patients who are failing or struggling with office-based buprenorphine treatment in their community, integrated community sites, OBIC offers restabilization services, including increased visit frequency, reassessment of the appropriate level of care, individual or group counseling, toxicology testing, and the option of frequent observed buprenorphine dosing at the CBHS pharmacy downstairs from our clinic. And the value that these provide is a safety net for both patients and providers. And I feel it really helps meet and treat the patients wherever they are in the dynamic journey of recovery. I told you I would tell you a little more about our services at 1380 Howard Street, and the functional aspects have to do with the co-location with other services. So we have, as I said, BHAC, the Treatment Access Program, and the CBHS Pharmacy. BHAC, the Behavioral Health Access Center, helps people access care by psychiatrists and therapists. The Treatment Access Program, which as I said is both a referral and a walk-in center, can refer patients to substance use counseling and even perform it there on site, can refer patients to medical detoxification or to residential treatment. And then the pharmacy, as I said, is on the first floor of the building. Not only is buprenorphine on the behavioral health formulary for San Francisco Department of Public Health, but the medication itself is purchased by our DPH. And the CBHS pharmacy administers and dispenses buprenorphine for patients who are in care at OBIC, and also for some community patients who are prescribed buprenorphine in their integrated settings. For patients who have Medicaid or Medicare, the pharmacy is so small they try and refer most of those patients to other pharmacies. But these are for patients who, for various reasons, may not have access to Medicaid, Medicare, and other insurance. And so many of our patients are indigent, and so many of our patients, even under the Affordable Care Act, will not be able to apply for those programs because they're either undocumented immigrants or because of past legal charges if their Medicaid is associated with a disability of some sort. So the pharmacy remains a treatment constant for so many of our patients, even if after they transfer to the community. And the clinical pharmacists are just amazing. Patients are often identified by the clinical pharmacists as being in some sort of distress. Maybe the pharmacist will smell alcohol on their breath, or the patient will appear intoxicated, or may not be oriented to the date or to the event. So they'll send patients upstairs for further clinical assessment before the medication will be dispensed. They also provide prior authorizations, and the pharmacy, amazingly, will also call the buprenorphine prescribing physician several days before a medication pickup refill is due, or if patients are late for medication pickup and it's reshelved, the pharmacists will call the prescribing physician and let them know that they had to reshelf the prescription because, of course, that may indicate a risk for relapse, overdose, etc. Another function of OBIC is our clinical documentation and our Department of Public Health's electronic medical record, which contains up-to-date clinical information viewable by a whole range of health network providers. And all of this, of course, has to be adherent to 42 CFR. At the OBIC orientation appointment, patients sign a consent form acknowledging their OBIC treatment will be documented in the eClinical record and that other providers will have access to that information. So OBIC progress notes can be seen not only by primary and mental health care providers that are accepting the patient who's referred for maintenance treatment, but also to other clinical services who see our patients, such as the emergency department or the hospital inpatient units or even the county jail, where, by the way, patients can be continued on buprenorphine treatment despite being detained. And the value of this function is improved communication between a whole range of multidisciplinary providers, and I really believe it enhances the continuity of patient care. And a final integration function that I want to emphasize is that OBIC, as I've mentioned before, is a training site and consultation service for community mental health and primary care providers, helping educate and train a whole range of providers, including physicians and nurses, social workers and counselors. And I really feel the value this offers in an integration effort is increasing the skillfulness and confidence in providing integrated office-based buprenorphine care. So to cover the second objective of this presentation, barriers to integration, I want to present how OBIC has addressed and responded to different concerns posed by the integration of buprenorphine in primary care or mental health care. So our community, our provider colleagues in community settings often mention they don't have addiction counseling on site. And I have the feeling that at some point in time they must have been told that it was a requirement for office-based buprenorphine treatment. It is not. The physician who treats opiate replacement with buprenorphine must be able to refer patients to counseling, and there's a whole range of possibilities there. But on-site counseling is not a requirement. The referrals, of course, include peer counseling and support, such as NA or AA meetings. And I see there's a PCSS webinar coming up very soon about that. Providers can also refer patients to OBIC for counseling, as I've said, including patients who have already transferred to community-based care. OBIC counseling includes individual and group formats. And in the San Francisco Department of Public Health, through BHAC, which I mentioned, providers can make referrals to psychotherapy focused on addiction therapy. There's a whole range of other resources that can be used, like Smart Recovery, Women for Sobriety, and many more. Furthermore, if you have a nurse at your clinic, nurses at every level can provide counseling, and this can always include psychoeducation, but additional therapeutic modalities may be employed depending on the nurse skill level and preparation. As I've mentioned, motivational interviewing, harm reduction education, and maybe other various psychotherapeutic modalities like cognitive behavioral therapy, DBT, etc. Waived physicians can be inspected by the DEA to ensure adherence to office-based buprenorphine regulations. It's not a lot of work, and it involves just a few elements. And let me say that in almost 10 years and almost 1,000 patients, OBIC's physician hasn't been inspected, but we're certainly ready should the inspectors come. We understand that in California, their route is supposed to take them every 5 years to each buprenorphine prescribing physician, but we've got a large provider population in California. It's important to understand, I think, that the DEA inspection is not an audit. An audit determines accountability for controlled substances that are received and dispensed, but this is an inspection most commonly, where the DEA only looks at records required to be kept in an office-based buprenorphine setting. And in most cases, practitioners will be inspected, not audited. So for inspection, DEA waived providers should have records or copies of the following at the location listed on the practitioner's DEA registration site, including a copy of their DEA registration. If you have a state where there's a state narcotics license, you should have a copy of that, and a copy of your state medical license. We also recommend that a physician maintains an active log of buprenorphine patients to show the number of patients that are receiving prescriptions. There are limits of 30 or 100 patients, and an active log can really help with that. And let me tell you, at one of the DPH community primary care sites that provides a lot of patients with buprenorphine treatment in a primary care setting, they have a nurse coordinator dedicated solely to the nurse management of the buprenorphine integration. And she tracks progress of the patients, communicates with the physicians, and she manages the buprenorphine prescription logs and refill needs. And I see that as really a nursing value added at that particular clinic. Another potential problem at a lot of public health sites and other health sites as well is that nurse practitioners and physician assistants are prohibited by law from prescribing buprenorphine for opiate replacement. And this is especially problematic at clinical sites where DEA waived physicians are not always on duty, or in sites where the DEA waived physician is only there a few hours a week while the mainstay of clinical staff may be comprised of NPs or PAs. And this is exactly the case at OBIC, where we always have an NP on duty, but the DEA waived physician works only half-time at this site. And what is the solution? Well, I think one of them certainly is careful communication and contact at all times that the clinic is open with the prescribing physician, and certainly we have that. But I think it's also important to acknowledge that nurse practitioners at our clinic provide every other aspect of care consistent with their scope of practice. And this includes making a diagnosis of opiate dependence or opiate use disorder, determining appropriateness for opiate agonist therapy, and performing intake physicals and assessments. At OBIC, the nurse practitioner then phones the physician who's available by pager during clinic hours. We give a report on the patient, and the physician gives the order for buprenorphine. As I've already mentioned, the nurse practitioners provide patient education, counseling, and some forms of therapy, and nursing case management for multiple patient needs. Again, there's this sort of this consistent message in 2011 from the Institute of Medicine, most recently from the Federal Trade Commission, the report of just a week ago, that really emphasizes that nurses at every level should practice to the full scope of their capability. And there isn't much that prevents that except for the buprenorphine prescription itself. And then there's concern about 42 CFR and confidentiality. Of course, integrating addiction care with primary care or mental health care requires information sharing, and that requires adherence to the privacy protections guaranteed under 42 CFR. In other words, there need to be consents from the patient for all interactions between OBIC and other clinical entities, including the pharmacy, in order for OBIC to share the protected health information. And sometimes that means a lot of signatures, right? Well, what's the solution to that? You know, I hate to say it, it's really to be adherent to 42 CFR. But I'll say this, once the required consents are in place, it's really easy to share protected health information about buprenorphine treatment. And that's the whole idea of integration. I want you to contrast this with the sometimes frustrating situation that many clinicians have faced, where patients in methadone treatment refuse to let their medical home clinic know that they're on methadone. Or when a patient does not want their methadone clinic to know about the Phenergan or Soma prescription they get from their primary care physician. So at the OBIC orientation appointment, we let patients know that we need their consent to document notes in the e-clinical record, to fax orders to the pharmacy, and to inform their current or eventual community provider about their course of treatment at OBIC, and that without their consent, OBIC can't do the job of integrated care that it was created to do. How about when OBIC asks a doctor about the possibility of prescribing buprenorphine at their care site, and we get this response, which has happened: our clinic doesn't provide opiate replacement. Methadone clinics do that. Well, really, our attitude has been to provide education about appropriate levels of care, patient-centered care, and that certainly there's an option that isn't methadone for opiate agonist therapy. And despite the fact that buprenorphine has been FDA approved now for 11 years, there are many providers that it just isn't on their radar screen. So I think an attitude of encouragement and information, if people are open to it, is certainly the best one to take in our experience. So an interesting thing happened once OBIC was up and running, and once we were inducing and stabilizing patients and transferring their ongoing care to a community provider. And it was this: the community providers were never changing the prescription pickup frequency that existed at OBIC. So if patients were coming to us once a week, as they often do, the community provider would continue the once-weekly prescription pickup, which really was not necessary in many cases. So we've always worked with clinicians to encourage individualized treatment plans. OBIC is always available to consult with providers on questions of level of care and other aspects of treatment plan, and we often get phone calls about that. And hopefully the providers feel comfortable consulting with one another and with us about the right level of care. The approach in integrated care, in my opinion, should always be to have a team-based element, and it's just too hard for any one provider to stand alone and say, boy, I've got to figure this all out on my own. The toxicology test results, how to interface with the patient, the prescription pickup frequency, the visit frequency, etc. I always encourage clinical sites to really take a team approach with that. And really, if there's only one take-home message from today, I would like to encourage that to be the take-home message, that with integration, no provider should be alone. I want to thank you for the opportunity to present our clinic and how we increase access to treatment and integrated care. I hope I focused on some specific functions that can be patient and provider-centered in order to facilitate integration. I hope I've been able to show how we've addressed some very natural and understandable provider concerns. And throughout, I hope I've talked enough about how nursing and other health professionals should function within the full scope of their practice to assist with the integration of the medically assisted treatment of opioid dependence or opioid use disorders. So I want to thank you for your time this morning and attention, and it looks like we have really a full 15 minutes or so for question and answer, and I'm happy to answer anything I'm able to.
Matt, thank you so much for an excellent and informative presentation. And as he pointed out, we do have time for questions, and we have some that have come in. Let me just start with, I think, a relatively easy one. You mentioned at the beginning of the presentation about the pharmacy that is connected on the first floor, and question about whether that's an inpatient or an outpatient level pharmacy.
That is an outpatient pharmacy.
Okay. All right. Great. Another question. Do you perform general anesthesia rapid withdrawals from opiates?
We do not. At the orientation appointment, we have a couple different approaches, and it's really very patient-centered. At the orientation appointment, we really try and prepare patients who are opiate dependent to be in enough withdrawal that the buprenorphine will alleviate withdrawal. And we're very clear that if they're not in an appropriate amount of withdrawal, in other words, if they take too much buprenorphine too soon after they last used, that it may precipitate withdrawal. And we don't mess around with language on that. We say it will act like Narcan. And our patients typically say, you got it. And, we let them know we don't want them to have dry heaves and be dehydrated in our waiting room. We want them to feel like, boy, I would have used a couple of hours ago. And we say, most of the time then when we give some small doses of buprenorphine the first day, each small dose makes patients feel better. So that's sort of the environment. But, some patients, it is very distressing, as I think probably all people on this phone call know. It's very distressing for patients to be in opiate withdrawal. They really feel not just physically ill, but really emotionally dysregulated as well. And if patients cannot show up in opiate withdrawal, our clinical attitude is this: if we dispense to them a small amount of buprenorphine, many patients can do their own inductions at home and even on the street. Our instruction is, when you feel sick enough that you would normally use again, instead of using, take a small amount of buprenorphine. And we have found that our patients are really able to self-induce. Who knows better than a heroin addict how important it is to dose on a regular basis? So we really sort of put that, we work with the patients on that. But no, we don't induce withdrawal before starting the buprenorphine.
So as a follow-up to that, could you give some more specifics in terms of describing the induction process, and is face-to-face time with a physician required?
In the induction process, we schedule our inductions on the days that the physician is here. Now, there have been times that the physician has not been present, but we have been in contact very, very closely with the physician and give a full report on that, on the patient condition. But almost always the physician has been here in place, and we plan it that way.
Okay.
And sorry, in other aspects of the induction process you asked about, really the core of that is the clinical tool we use the most is the COWS, the Clinical Opiate Withdrawal Scale. We really like that because of the combination of objective and subjective withdrawal symptoms. There's a couple other opiate withdrawal tools as well. But as you know, the CSAP publications and 8-hour physician trainings on required for the DEA waiver for buprenorphine really spell out the elements of the induction process. That includes a drug use history, the most recent drug use, comprehensive history, a physical exam, a psychosocial history, family history, history of treatments and addiction, et cetera. So all of that is I think, pretty standardized, and we really follow that CSAP piece very closely.
Great. So that kind of leads into another question, and is there a good place to get a treatment algorithm, for example, the dose, observation, et cetera? And along with that, others many on the call may be familiar with the cows, but could you talk a little bit more about that and just in terms of it is publicly in the public domain, correct?
It is. You know, CSAT has the buprenorphine, the TIP, the treatment protocol booklet for buprenorphine induction, and treatment algorithms are, as I recall, included on that. I believe CSAT, I had heard, maybe somebody on the call knows, is working on an updated version of that at this point. That really is kind of our training go-to site for those treatment algorithms. Cal's sheets, the appendices in that tip, I think it's, I'm not going to try and guess at the number, I apologize.
Yeah, it's readily accessible at the on the website.
Right.
SANSA. Mm-hmm.
And the indexes and appendices in that tip are very, very helpful for, you know, the Cal sheet, the history, the elements of opiate dependence. I suspect one of the updates on the new version is going to be the elements of the DSM-5 diagnosis of opiate use disorder instead of opiate dependence, or as it was in the past version. So I think that's really probably the best resource in a single site.
Mm-hmm. Great, great. Can you talk a little bit about how payment is arranged for services you're providing? And this may be somebody who may have missed the beginning early on, but in terms of whether it's private insurance, cash, Medicaid, Medicare.
Yeah, we're actually very lucky because, as I did mention at the beginning, buprenorphine as a drug is on our Department of Public Health behavioral health formulary, and the Department of Public Health has actually purchased buprenorphine for the CBHS pharmacy to be able to dispense that at no cost or very low cost copay to patients with Medicare, or here in California, our Medicaid is called Medi-Cal, and with a prior authorization or TAR, those two government insurances will cover the cost of buprenorphine. For patients with private insurance, as you can imagine, we're going through a sea change, as everybody is, with the Affordable Care Act. We used to only accept patients with public health here in San Francisco, or Medicaid, Medicare. And we're really sort of in the thick of the process of figuring who, with new ACA insurance, are we seeing. One of the big providers out here in California, Kaiser, provides buprenorphine, but they're also contracting, I understand, with some other agencies to do opiate replacement care. So we're really right in the midst of that huge change. It's been very easy for us, though, up until now, because we haven't accepted payment. It's all part of the Department of Public Health benefit. And to that end, one of the difficult things that we do is we get calls from, you know, people in their late teens and 20s saying, hey, I live in, you know, Alameda County or Marin County, and I'm on my parents' insurance. I don't want them to know that I'm opiate dependent. Can I come and get free treatment at your clinic? And unfortunately, we have to say to them, no, you're not eligible. It's only a San Francisco benefit.
Mm-hmm.
Difficult.
Right. And I think, as you point out, the Affordable Care Act is going to have, it's going to keep all of us on our toes for whatever we're doing in healthcare. So stay tuned. So specific to your statement about not having a Data 2000 waivered physician on staff, cannot physicians prescribe buprenorphine as part of the 3-day rule, when wherein non-data waivered physicians can prescribe buprenorphine for up to 3 days?
You know, I am not equipped to answer that question, and if, I mean, maybe there's a physician or pharmacist or other expert in that area on the call right now who might be able to type in an answer for it, but I'm just not equipped to answer that.
So it may be another response later on from the same individual talking about take-home unobserved induction protocols that are used, have been studied, so identifying Lee 2008, and also referencing Gunderson, say, PCSSB mentor. So, you know, I think some of these questions may be helpful to engage in the communications with the PCSSB mentors that, well, you can send a question in and you'll get a response back. So another great resource that's provided through this series.
Yeah, thank you so much. I mean, that really is one of the nice things about these webinars. And isn't Dr. Gunderson going to be involved? Isn't he involved now in the PCSS for the upcoming years? Through a MRSA, I believe he is.
I believe so, yes. So there's some very active clinicians that are providing mentorship, and so for people who really want to know more about that, it's very easy to access, and we can even provide some of the information and links on our website. What percentage of patients come to you from methadone OTCs wanting to switch to buprenorphine? And do you work with those clinics who are starting up to offer, who are also wanting to offer buprenorphine to their clinic, to their patients?
So these are questions I can answer easily and happily. 20% of our patients come from methadone clinics. And we do work with other clinics. I've just been in very close contact over the past 2 years with Dr. Solotaroff, who is getting a buprenorphine induction clinic up and running in Portland, Oregon at a big FQHC up there. So yeah, we've had lots of long distance calls with, a couple of long distance calls with hers, and then at conferences and things that our staff interacts with other folks. So we're always happy to consult on that.
Great, great. And can you talk a little bit about your patient numbers and the limited physicians on your staff? You've got a half-time physician. How do you manage the 30 or 100 patients per physician restriction?
Well, as you can imagine, it's kind of like a constant turnstile. So we maintain anywhere between about 15 to 30-something patients at any one time who are getting prescriptions from our DEA waived physician. So her active prescriptions never, they never exceed her limit of 100. They never even come close. And the particular patient log that we have for our active buprenorphine patients, we have a column for the active buprenorphine prescriptions for this physician. So whenever a patient transfers to another provider in the community or elects another treatment, for instance, they say, boy, this methadone just doesn't feel good to me. I want to go back to methadone treatment. Buprenorphine doesn't feel good. I want to go back to methadone treatment. We'll -1 on the total number, the total count of patients who the physician is prescribing for. So day to day, we have an accurate running tally of the number of patients we have. Typically, we get 1 to 4 new patients a week, and typically 1 to 4 patients graduate out to the community or move on to other treatment.
And Matt, I think that really underscores the point you made in your presentation about tracking, having that patient log and tracking the number of people that are on active prescriptions and how critically important that is to make sure that you're within the regulations.
That's right. The DEA, if they do an inspection, will want to know that.
Sure, sure. How do you deal with after-hour presentations of problems, such as the person who's out of medication, presented to the ER with pain, maybe a motor vehicle accident or assault, admitted to the hospital, especially if attendings are in the ER, OR, who are there are inclined to go on I think the question is about, kind of how does that get managed? And when somebody's on buprenorphine and they're presenting with these after-hours presentations at emergency settings.
Sure. It's a great question. We do a couple of things, first of all, to sort of prime the system in case that should happen, and sort of, I mean, in a sense, it's kind of poor outcome prevention. One is we really inform patients, look, if you have acute pain and end up in an emergency department after a bike accident, a car accident, etc., we reassure the patient. An emergency department has ways of administering medication, pain medication, that can get to you and be effective, so please don't worry about that piece. We give them, if they want, a little card to carry with them or in their wallet describing that they're on buprenorphine. And then our charting system, of course, the e-health records, if they end up at the county hospital or in a county acute care or urgent care site, they'll be able to look up when they open the patient chart and see that they're on buprenorphine. As many people on the call know, full opiate agonists, as we've learned over the last 11 years, can certainly be effective still for analgesia for patients on buprenorphine. So that's another piece as well. Now, if patients, I'm kind of anticipating a follow-up question, so I hope you don't mind my saying that patients who end up hospitalized, maybe on full opiate agonists, not on buprenorphine, we simply sort of re-induce them after that process the way we did originally. So we're in touch with patients who are hospitalized. We encourage patients and their social workers and attendings while they're hospitalized to stay in touch with us, because if buprenorphine is appropriate again in the near or more distant future, we're happy to be involved in the reinduction process to get them off the opiate agonist for analgesia and back onto buprenorphine.
So, and I think to follow up of maybe the intent of this question as well is it may be the concern of those emergency providers who say you're already on or you're on buprenorphine, I can't give you any other narcotics or a narcotic. And I think to your point about other analgesia medication, maybe that's another opportunity for education around what can be provided to manage that pain for somebody who is on buprenorphine.
Absolutely. That's a very good point, Deb.
So you mentioned earlier, we have a specific question about any clinics in other states, and you mentioned earlier about the locus tool, I believe you mentioned.
Yes.
Was that to find providers?
No, that is level of care. So what is the appropriate level of care? Do patients even need medically assisted treatment for their addiction, or would a social model be more appropriate for them if they don't have serious physical dependence on opiates? Or is their physical dependence and other problems so severe that they maybe need to be hospitalized or an inpatient medically managed? That's what the locus does.
Got it. Okay.
To find physicians, though, who prescribe buprenorphine, it sounds like is in that question, we actually use SAMHSA's buprenorphine locator.
Right.
So if on your search engine you just type in SAMHSA, SAMHSA, and buprenorphine physician locator, you'll come up to the great SAMHSA website of a map of the U.S., and you can click on a state and then search either by zip code or by provider name.
Right. Well, Matt, I want to thank you. This has been a great Q&A period. I think we did get through all of the questions. It looks like that that came in during this time. So I want to thank you for your time, for presenting today, and for fielding those questions. Before we close, I just want to let you know that you participants will receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey, and we do ask that you take a few minutes to access it and provide your feedback on today's session. The webinar today was recorded and will be posted on the website of the Physicians Clinical Support Opioid Therapies in the near future, and that website is www.physicians pcss-o.org. And that's also where you can find other resources, including some of the mentor resources that were discussed during the Q&A period. There's a calendar of upcoming events and helpful clinical resources there as well. All of this information can also be found on the INSA website at www.intnsa.org. And we hope that you will join us for our final sessions for this part of the series, and we'll have that posted on our website, again, www.intnsa.org. Again, thank you very much, and have a great rest of your day.